Okay, so I'll go ahead and do my introduction and then I'll let you take over. So I just want to thank everybody for joining us today. Um, and this series was created to support clinicians with continuing education, telementoring, and collaboration opportunities to increase quality of care and support for persons living with dementia and their caregivers in rural areas. Today's presentation, Spotting the Signs, Early Detection and Diagnosis, is brought to you by Dr. Jonathan Singer. He is the Assistant Professor and Director of the Garrison Institute on Aging Memory Clinic. Before we dive in, we just want to take a moment to recognize the organizations that make this program possible. So this program is supported through DSHS and is operated through the F. Murray Hall Institute for Rural and Community Health at the Texas Tech University Health Sciences Center in partnership with the Garrison Institute on Aging. And then again, please make sure if you are new to the series, please make sure you complete the pre-series survey. There is, if you look through the discussions, there is a you can find the link to it as well. And then again, at the end of this session, if you can provide please complete the post-session echo. That will help us improve the future of the program. So, and then again, CME credit is available for today's session. So please make sure you download the handout and follow all the steps. And please mute your microphones. There will be an opportunity to ask questions at the end of the presentation as well. So with that, Dr. Singer, I'll hand it over to you.
Thank you so much. Appreciate it. I want to share. Let's see if I can get this right. Okay. Can everyone see my screen? Woo! Awesome. Yeah, thank you so much, Rachel. And it's great to be here and to speak to all you today. And thanks so much for being here and being part of this really important colloquium for the next, I think we've already had 2 weeks and then 3 more weeks, but very exciting. And you're really taking the first step in helping individuals with dementia and helping your community. So thank you again for being here. My name is Jonathan Singer. I'm a clinical psychologist by training with the specialty in neuropsychology, and I have a dual appointment at TTU and HSC, and I work in the GIA and really have enjoyed that. Today, I'm going to talk specifically kind of where Dr. Culberson left off and talking about, what do we do? How do we spot the signs, right? You guys are all very busy clinicians, and how are you able to spot the signs in these 15 or 30-minute sessions? And so how do you do that, and how do you able to manage the possible cognitive impairment with all the other things going on? So this could be probably a whole project echo of 6 to 8 sessions, but I'll try to fit it into one today. And then I don't know if there's a case presentation that anyone wants to bring up a case that we can discuss, but if not, I have one prepared that kind of fits with what we're talking about today. I've also I know we were waiting for questions at the end, but if there are questions that come up, feel free to interrupt. And also, I like to be very interactive. So if you would, especially during the case presentation, if you want to unmute and discuss anything I'm talking about, please let me know. So I have, okay, let's see if I can just, I have no disclosures, but I will say I'm the director of the memory clinic, obviously, so I have no financial disclosures, but I will talk about the memory clinic a little bit throughout and kind of what we do. It doesn't mean that that's the perfect system, but it's just a system that we use. So I want to talk a little bit about Alzheimer's disease and Alzheimer's disease related dementia. You got a little bit of this before, but I'll talk a little bit about the disease, the prevalence of the disease, and specifically here in Texas, because I think that is really important when we think about what we're looking for in people that might be at higher risk than other individuals. And then identifying the signs. How do we identify these signs? And that will be the kind of backbone of today, as well as then a case presentation at the end that I'll give. So you probably all have seen this. This is that umbrella term where we have Alzheimer's, Lewy body, vascular, frontal temporal, and others. And so the reason I bring it up and added this kind of other part of the graphic was that to really highlight that Alzheimer's is the highest prevalence. So it's 60 to 80% is what we see. And then it goes down to Lewy body vascular, frontal temporal. So you'll mostly be seeing individuals that have Alzheimer's disease. However, these other types. The other thing I'll mention is that literature has been coming out recently to really highlight that there's been some underdiagnosis, is what we think of more mixed dementia. So that's that Alzheimer's and vascular combined is kind of what we see a lot of times, but it could be Alzheimer's and Lewy body as well. So just keep an eye out that something might look like Alzheimer's disease, but also could be vascular. And that's really important actually when we talk about the progression of the disease, which Dr. Bertelson talked about a little bit in the his first session. But if somebody has this kind of, we call it staircase presentation, and you're like, this is Alzheimer's, that's not fitting with that. It could be a mix between Alzheimer's and vascular. So it's really important to understand that it could be mixed as well. So I always like to bring that up, that just because it's Alzheimer's doesn't mean we shouldn't rule out other types of dementia as well. The other thing I like to bring up, because this disorder affects the whole family. And so in our clinic here, we really focus on the whole family, not just the patient. And the reason I bring that up is this exact prevalence. So we all know prevalence is increasing, but what I like to point out here is this top part here, these top lines. We're seeing the biggest increase in individuals that are 75 and over and 85 and over. And that's concerning to me. And to it should be to you as well, because what that means is that there's going to be more onus on the healthcare system as well as caregivers and family members to play that role. And these family members then are going to be much older, if the person with dementia is older. So that's just something to kind of think about as we're going through this, is that as we age, obviously our risk goes up, but that we're going to see that huge increase because people are living longer. The other piece of that, where I think is really salient to kind of most of you as primary care physicians, is that there's more comorbidity, there's more polypharmacy, and there's more things to consider and that need to be considered. And so that's really important when we're thinking about dementia as a whole, is it affects the caregiver, affects the family, affects everybody, which now they could be older, as well as these other aspects of polypharmacy and comorbidities. So something I like to bring up, that we need to dig into the data sometimes to understand really where that prevalence is increasing. The other thing that doesn't get talked about enough, and is specifically the impact on women. So we know that about 65% of Americans with Alzheimer's disease are women, and we know women are a lot more likely to be caregivers, which now is a risk factor for dementia because of all the stress, burden, etc. Um, and so, what we know is that 10 million women in the United States are have a form of dementia or are caring for somebody with dementia. So that's a huge percentage of our population. But one of the things that I know we see in our clinic, that comes up every once in a while, is that it's usually actually the men that come in. We have higher rates of male patients that come in. And I always like to ask, like, why do we think that is? And a lot of times it is because their wife or adult daughter is bringing them in for care. And what that's actually resulting in, and there are some research articles on this, that it's resulting in women actually are being diagnosed a little bit later or not diagnosed at all. So that's pretty problematic. So just keeping an eye on that. So we've even had patients here, not a ton, but a few patients here where we're actually have the person with dementia, the male, and then we notice some signs in the woman, the caregiver. And so we actually recommend that the caregiver get an evaluation as well. So something to think about if you're seeing kind of families or maybe their spouse there, that to keep an eye on the caregiver as well. And so this is just kind of one of this impact on women specifically. The other thing that this graph kind of lays out is that women live longer. So what you see is that after the age of like 70 on, or about 80 on, excuse me, you see this flip from men being diagnosed more, having it more compared to women. And so that's really important to understand when you go back to that first graph that I introduced, whereas like people 80 and over are being diagnosed with dementia more, that prevalence is going up. Well, that's mostly going to be women actually, because of women living longer. So just some things to keep in your back pocket, and understanding of kind of what you might be seeing in your clinic or things you might not have thought of as well. So just to consider those things. Now I want to kind of drill into Texas, and I had these slides I got from the Alzheimer's Association But one of the things that is a little concerning, and many of you might know, is that we have a huge increase in individuals with dementia across the state of Texas, but our workforce of geriatricians, of behavioral neurologists, of neuropsychologists, of geriatric psychiatrists is all going down. So it's not meeting the demand that's needed. And what that means is that our caseloads are going to go up. It means that a lot more pressure is going to be put on the primary care physician to care for people with dementia, as well as sometimes even if there's not access to diagnose. And so that's something to consider too, of like, how do you, and I know Dr. Colbison talked about a little bit, how do you maybe try to structure your clinic a little bit more or try to find different ways to help individuals who have dementia, give them a little bit more time if possible? Are there other codes, billing codes that you can use to try to make that more advantageous, obviously, from a business side as well? So, something to think about as well, that we're only going to see this increase in the number of people, but we aren't seeing an increase in the clinicians. The other thing that we're seeing is that access to care has been quite challenging. And now, I think in future sessions, you're going to talk about the two medications that are out to the infusions that are out to reduce and to slow the progression. And these are infusion medications. So, at least for the first 18 months, they'll be on an infusion medication every other week, or if they're on donanemab, they'll be on once a month. And this is, concerning for our rural population, where, as you can see here, many people are, very far. They're quite a distance from a doctor, even a primary care physician, let alone somebody infusing the medication. So that's problematic. And so we need to think about, when we're thinking about care coordination, kind of how we're going to do that. And if you see somebody with the signs and you try to get them worked up with a neurologist, what's the barrier to getting them into that neurologist or into that memory clinic? So when we talk about the signs, we'll talk about, things we can notice, but then what do you do next? And I think that's the thing that this hopefully will give you a nice sense of, here are the signs. And what do I do next? And then Dr. Bertelson next week will talk a lot about, or in 2 weeks, we'll talk a lot about how to manage it and how people have been able to successfully, as primary care physicians, manage this over time. So I'm glad that he'll be speaking on that as well. So I want to jump into kind of the meat and potatoes of what I'm be talking about today, and that's identifying the signs. And so um, I would be curious if anybody is willing to tell me kind of what are the things that you look for in your patients. What do you kind of are already doing maybe to see if they have dementia, even if they don't come in for memory concerns, right? That's the easiest one, is when they come in to have memory concerns. It's the ones that are coming in and have memory concerns but don't tell you. So I'm curious if anybody's willing to um, speak up of kind of what you are already doing. And if not, I can keep going. I know some people might be eating lunch or doing other things. So, okay, I'll keep going then, and kind of go into identifying the signs. So I have it broken up into kind of overall signs, and then I have different domains that you can really think about. So um, let's talk about overall how we identify the signs. So when I see a patient, these are some things that I look for and that I kind of am looking, no matter if I'm seeing somebody for maybe they have ADHD or for clinical purposes or depression or whatever, I'm looking for these signs as well. So you might ask things like, how are you doing today? And they might say, I'm just feeling tired. I didn't sleep well last night. Those types of things. When you're giving things like the MoCA or MMSE or SLUMS, we're going to talk about a little bit later, for their 1 year evaluation, if they have Medicare and they're 65 and over, they might just be saying, I didn't do as well because of these things, because I'm feeling tired, I didn't sleep last night. These are things that they might be saying. These screeners are okay in a way at getting at, if they are tired, that could affect it. But if you're seeing somebody and it's a very low or a score, usually that's not due to just being tired. So something to kind of think about when you're giving those measures. But I've heard from a lot of patients, oh, I'm just tired today, or oh, I can't remember, because I didn't sleep well last night. Those are indications where I'm kind of like, okay, we need to figure out if further testing is needed. The other thing that we look for, and we're lucky enough to have a family member usually accompany them, is if they're not answering the questions and they're constantly looking at somebody else, like a family member in the room, to answer the question, and that family member is answering, that's where I start to think that's a sign, and that's something that I should definitely start asking more questions around. So specifically, I might ask things like, just to patient Mr. Smith, Mr. Smith, why don't you tell me this? And just kind of directly make sure you're asking them, and then see if they're still looking at that person or if they don't remember. And because a lot of times you'll get the caregiver will start answering those questions when you get short answers consistently. And now some people just aren't talkers. And so if you get short answers, yes or no answers to these open-ended questions. So if you're asking, very open-ended questions and you're getting yes or no, or you're getting I'm fine or nothing's wrong, or, those types of things, you might want to try to ask more questions and try to understand, are they not understanding your question? Do they just not know how to respond? Do they not have the right word to respond? And we'll talk about that in a little bit. The other thing, as far as that's kind of patient's responses, as far as patient's body language, what we're looking for is, are they making eye contact with you? Are they able to actually look at you and make eye contact? That's really important. Are they just staring at the ground or maybe just looking at their caregiver constantly? Those are indications as well. Sometimes I'll see people just shake their head repeatedly. And so when they shake their head repeatedly, of like you're not really asking a question, they're just kind of shaking their head. Sometimes that's what we call a compensatory behavior, and a behavior where they're not sure, they're not understanding what you're saying, so they're just shaking their head yes or shaking their head no. So I look at that and I look at their body language. I actually pay attention a lot at a person's body language. You can tell a lot about that. And then I look at, if you have the family member in the room, the interaction with that family member. Is the family member answering all the questions? And there could be even excuses like, oh, she answers all the questions, she'll do all that, or he'll do all the question answering. It's like, no, I want to hear from you. I want to hear how you're doing, specifically. So I ask more direct questions to the patient. Um, Sometimes you'll see the patient will start to answer and then the caregiver will interrupt. And the caregiver will interrupt the patient's answer. And that might be because, one, the patient's wrong with their answer or incorrect. It might be that they're misremembering, but that's all important data that you need to consider. And so that correcting the patient is really important as well. So no, we didn't go to, Denver last weekend. That was 2 years ago. These are all things that we should be paying attention to. And so I did put this note on the bottom, I think is really important. Anything, not just this slide, but anything I say coming up, if they have this, it's not a causal, they have this, they're not making good eye contact, they have dementia. That's not what we're saying. What we're saying is these are indications that they might, and that you need to maybe do further follow-up, or you might need to refer out. So I just wanted to kind of mention that note is like, sometimes I hear from my students, my doc students is like, oh, they have this, so they must have dementia. It's not causal. These are things that are symptoms that could be that reason, but there's other reasons. There's polypharmacy. There is that could be causing some of these. So we don't want to jump to conclusion, but things to look at. So when I think of symptoms of dementia, what I'm really thinking about is different domains, and I'm thinking about them really in five domains. And that neuropsychologist in me kind of comes out a little bit, as you can see through this of the five. So this is memory. Obviously, they have to have some form of memory deficit, executive functioning deficit, language deficit, visual spatial deficit, and behavioral and personality changes. So one of the reasons in our clinic, I can talk more about, we don't use screeners in our clinic. We use what's called the R bands, because it gets at these domains and helps us a little bit more. So this is a test we give, as well as the trails and clocks, to try to get a little bit more at these different domains to help us, because it's hard in a 15-minute session to get every piece of this, but we're going to go through the case presentation in each of these domains to understand, what that might look like. But I'm going to go through them first. So the first one is probably the easiest one, and this is the memory signs. So when we're talking about memory, we see a lot of times they might be repeating the same story. They might have told you the same story if you're seeing them more frequently last week or a couple weeks ago. They might be repeating the same question or to you. So they might say, at the begin, I've had this happen where at the beginning of session, you're maybe saying, we want to up your donepezil to 10 or whatever it might be. And so we're upping your to 10. And then later on in when you're kind of finishing up and concluding, they might say, so what am I supposed to do with my medication? Or they might say, I didn't know that I was supposed to up my medication. So those are all indicators that there might be some memory concern. When you see patients, especially that you've seen maybe for a while and they start missing appointments, maybe not remembering appointments, maybe reaching out to if somebody has a power of attorney on file, to reach out to them or to reach out to a collateral to try to figure out if everything's okay. Um, Forgetting recent events, but recalling distant ones clearly. So they might not remember where they went to lunch on Saturday, but from the 1960s and 1970s, they can tell you the Yankees, starting order as far as their batting order, perfectly. Those are indications that, okay, maybe there's some concerns as far as that short-term memory loss. So we need to pay attention to that as well. So the next one is difficulty managing medication, finances, or shopping lists. So these are things like they're starting to forget things as far as being able to do things that they've always been able to do. Things that were easy or maybe not too difficult for them, but now we're just forgetting how to do that. And some of this, and some of you might be thinking, well, isn't a lot of this normal aging? And so towards the end of the presentation, I have a slide that kind of lays out normal aging and what we might expect compared to something where it's more concerning to us. But this is kind of what we look for as far as memory. So this is probably the most straightforward one for you and one you've thought about many times in your clinic. The next one is executive functioning. I actually have a student, a doctoral student, who just wrote her quals on executive functioning, and the literature is very interesting. So, executive functioning can mean a lot of different things, but in this sense, what we're talking about as far as executive functioning, we're talking about trouble planning tasks. So if they're having trouble planning tasks that seem pretty simple to plan, they might have more difficulty doing things multi-step. So doing two things at once, or we even talk about can you give them two directions? And if they can't do it, that might be an indication. The other thing is poor judgment we see under kind of this executive functioning bubble. So maybe like unsafe driving or maybe getting taken advantage of. So we see a lot of older adults, sadly. There's just so many scams out there. I was doing a assessment recently, and the lady said, I got 57 calls while I was in the 6 hour assessment from scammers. And I'm like, wow, that's pretty terrible. So we need to make sure that, they're not taken advantage of. They're not falling for these scams. And again, that doesn't mean that they have dementia, but it's one indication. We see more of the financial decision making that can be problematic. So these are people that are maybe giving somebody thousands of dollars or sending people money that they don't know. Those are kind of the poor decision making we're talking about. Also, things like that they're very familiar with, like cooking, or we've had patients who um, we had this Italian family who said like she's cooked these meatballs for 40 years and doesn't need a recipe, and now she needs a recipe and just doesn't know what even the next step is. That could be an indication that something is going on. So that's a memory slash executive functioning piece, but really important to think about. The next one is language. And so there's obviously when we're talking about things like primary progressive aphasia and then into like FTD, you see a lot more language signs. But even in Alzheimer's, you can see language signs as well, or what I quantify as language signs. So this might be something like word finding difficulty. And so a lot of individuals that are aging, what we see is that they will start to forget words. That's part of aging. Like there are words that just, I know the word, I can't think of it. What we're talking about here is more, I know what I want to say, but I can't say it. And I can't necessarily find another word for it. Or it's happening very often. It's not just happening once a week or once a month. It's happening more and more on a daily basis, multiple times a day. Um, Maybe too using the incorrect word. So they say something and everyone kind of looks like, oh, I'm not sure that's the right word for that, or I'm not sure what you're saying. Those are indications and language signs that we're looking at. Um, Trouble following conversations. So, this could be, if you're especially in a bigger group, and this is kind of the merge between language and executive function a little bit. If you're one-on-one and they seem to do okay, but then let's say there's three or four people around, and they're struggling following the conversation, which is going back and forth between a couple people, that could be an indication that there's something on. The other thing to always check with anybody, I'll just bring up now because I think it's a good time, is making sure they can hear, making sure they're having their hearing checked is really important because they might not be following the conversation because of hearing. But if you're like, nope, they can hear just fine, they just can't follow the conversation, or in the middle of the conversation, they interject something that's has no relevance to what the conversation is about. These are indications that we're really um, looking at. The other thing, and this goes back to kind of that overall what you might see in session, and especially if you've been seeing somebody for a long time, you might see this as that, they would come in and talk to you a little bit, be and discuss kind of things going on in their life, and now they're very much like one word answers, very vague in their answers, and their just verbal output is limited. And this is where the caregiver kind of sometimes has taken over as not necessarily like to hide on purpose, but to be that kind of compensatory behavior of like, nope, she's going to talk for me or he's going to talk for me. So that's really important to understand that that limited verbal output can happen as well. So visual spatial difficulties are a little bit harder to assess in clinic, but from information that you get, you can kind of decipher this. So we have measures that can get at, from a neuropsych perspective, visual spatial challenges. And so this might be difficulty judging distances. So maybe when they're trying to park or when they're trying to do different things, they have that difficulty getting lost in familiar places. So if they're going to a place that they know very well, or that they've been to many times and they can no longer remember how to get there, that can be problematic. One of the things we always talk about in our clinic is that most people that see us in our clinic go to church, and they've been going to the church for many years. And so one indication is, well, he or she's been driving for, 30 years to church and now they can no longer find their way to church. That's a huge indication that something's going on, and that we need to follow up. We also see, and this is usually more in the moderate to severe kind of further on, but we see problems with dressing. So putting clothes on maybe incorrectly, um, maybe even if you have a more frontal temporal presentation, you could see even like inappropriate dress or kind of, in the summer, having like four coats on type thing. So just problems with dressing, problems doing it as well. So just something to think about there as well. So the last thing is behavioral and personality changes. And one of the things that has come out or has been out for a while in the literature is that we actually see a lot of behavioral personality changes happen even earlier than any type of cognitive change. And the cognitive change might come at similar time, but usually we see those behavioral or personality changes first. Or we can, I should say, not everybody's that way. So I just wanted to mention that you might see some behavioral changes in these individuals, or the family might report their behavioral has totally changed. A lot of times, this happens a lot with FTD. We have one individual who was very much not a very warm person. He was very kind of cold in a way, is how his family described him. And since having FTD and being diagnosed has been warm, hugs people, kisses people, just does inappropriate behavior for sure, but like over the top of kind of that personality change 180. So just something to think about there. The other thing you'll see, and this is so important, why considering medication management and why Dr. Ayers works with us here and is wonderful as far as our geriatric psychiatrist, because one of the things that you'll see a lot of times is apathy or social withdrawal. And some people will just say, well, that's depression, and not pick up on this actually could be dementia too. Irritability, anxiety, depression are all things. You might see some inappropriate behavior at times. If their family's reporting this inappropriate behavior, totally shifts in behavior, doing things that they would never have done. You can also see things like them being suspicious or having paranoia. And these are kind of the behavioral or personality changes that are really important to kind of keep your eye on. So I always say when people are probably 60 and over and um, you think it's depression or anxiety or some other mental health concern, I always would consider in the back of my mind, at least, that it could be an early sign of dementia as well, and maybe just keeping an eye on it, keeping that in your back pocket of like, just in case, maybe we should do a screener as well. So these are the kind of what we look at in different domains and how you can kind of think about it to help you, hopefully. I want to talk about this because this gets asked a lot, especially when I talk to the public. Oh, sorry, it's a little hard to read, but hopefully you can read it. But is the normal aging versus dementia? So a lot of people will say, I forgot my keys last week, or, I forgot somebody's birthday. These are things that can happen as we age, but in these domains that are kind of broken down on the left, and I won't go through everyone in depth, but what we can see, like for example, memory losses, we might forget names or where you put things. That's kind of this normal aging in a way. Now, if it's happening excessively, that's where we get a little problematic, or where maybe they're leaving things in odd places. That's where we could be starting to worry, as well as we usually always ask, what are your children's names and what are your grandchildren's names? And if they can't tell us those types of things, those are good indications that we should probably do a further workup with this individual as far as the memory. The disorientation, like forgetting why you entered a room, that can happen with normal aging. So I walk into a room and I'm like, oh, why did I come in here? And I just can't quite remember why I came in here. And so that could be one indication that that's just pretty much normal aging. It could be. But if it starts to happening where, you don't know how to get home, how I mentioned with the church and going home from church, or going home from, if they have season tickets to the basketball games and they've gone home, 100 to 200 times in their life and now they can't remember, that's where kind of we get concerned. Specifically talking about money and kind of the poor decisions I mentioned before. With aging, we sometimes forget stuff like paying a bill. So that's kind of that normal aging, but where it could be possible dementia indicator is that the struggle to handle finances and maybe where it's very easy to do their checkbook, but now they don't even know how to do the checkbook or to pay a bill. And this is where we start kind of getting a little concerned. And that word, struggle, the using different words I mentioned. So sometimes struggling for the right word to use. And that can be one piece. But when it's difficulty following conversations, like I mentioned, that's where it starts getting concerning. So these are kind of broken down into the similar domains that I had before, but I just wanted to kind of mention these as well to kind of differentiate when somebody asks you, normal aging versus is this an indicator of dementia? I think it's really important to reiterate to people that um, there is normal aging and that you can't remember things when you're in your 70s as well as when you were in your 40s. Like it's just part of the aging process. The other thing that I wanted to mention is that I even sometimes we get 30-year-olds or 40-year-olds that might come to us and say, "Hey, I think I have dementia," and I say, "Well." what else is going on? And it's like, oh, I've been stressed because I have, many kids. I don't sleep well. I'm working many hours at my job. I'm stressed, these are all things that can affect our memory. So we do want to make sure that we are overdiagnosing people, especially under 50. So we want people really it's rare unless there's an intellectual developmental disability that we diagnose anybody ever under 50. So just something to consider as well. Um, Before I get into the case presentation, I want to talk a little bit about some of the things that we're doing to try to help with screening and other things. So, one of the things is we know in the rural areas, people are diagnosed later, and that's really problematic because now we have medication that can slow progression in those early stages. But if you get somebody in moderate to severe stage, that's where it can be more there's not as much we can do. So one of the things we're doing, and I think I saw her on here, but our team at the GIA and with Veronica, who runs our outreach division, we're doing a lot of these screening events throughout West Texas to try to screen people for it. So we're happy to come to your county, wherever you might be. But one of the things that you can see is obviously the southern part of the state, we see the highest prevalence. But here we are here, if you can see in this West Texas piece, we're actually in a pretty high prevalence region here, but our diagnosis are actually some of the lowest number of people diagnosed or diagnosed a lot in the moderate to severe stage. So I always like to bring this up of places that we just need to pay attention and to try to figure out, how to increase our screening and ability. So we're trying to do some of these events to expand this and to help our region as well. So if that's something that your county that might be advantageous to you, we usually couple it with a bingo night or something else we try to do to make it fun. But people have really enjoyed those as well. So I'll jump into the case presentation. I don't think there's one. I didn't hear of any, but does anyone have a case? I'd rather you guys present your cases than me present this case, but I'm happy to do that as well. Um, is there anyone, Rachel? Nobody sent one, right? Okay.
Okay. Correct. Yeah. And I don't see anything in the chat as well.
Awesome. I'll jump in then and give my case presentation. And all of this is made up. So there's no HIPAA violation or anything like that. So I'll just give this one, and I tried to make it very salient to primary care physicians. So Mr. Smith is a 72-year-old retired accountant who presents to his primary care physician accompanied by his wife. He is in for his yearly checkup. Toward the end of the evaluation, his wife mentioned that she has noticed he had some memory concerns over the past year, but states having memory problems are part of aging, right? Isn't that normal? I know I cannot remember some things. So, this is something that presents a lot to us, this situation. So, um, what would be those next steps? And what would be kind of what do you think you would do next? And obviously now it's at the end of your session. Maybe you had a 20 minutes until you have to see the next patient, so you're down to 5 minutes. Maybe what could you do in this time um, to kind of evaluate or to figure out what's needed, or if anything's needed? Does anyone want to jump in? Okay, I'll keep going then. So, one of the things that I would try to think about now that we have these five domains is to really try to figure out quickly, and I think you can ask questions quickly in these five domains to try to get at is there something concerning? And when you see somebody who maybe has some memory concerns, it doesn't mean that they have to have a problem in each of these domains. We see some people that just have memory concerns, they don't have language concerns. You really need the memory piece and then these other ones, but sometimes you'll just see behavioral personality changes, or maybe they're not noticing the memory concerns, but asking questions around these five domains are really, really important because they will help you get at, is this person need to be worked up more by a neurologist, or is this something that's a normal part of aging? And I know that's hard to do when you're in the short time you have, but I made up some questions or made up some responses that you might get. So, um, you might see that the patient responds to you when you ask them, they ask the wife or ask Mr. Smith, tell me a little bit how they're doing as far as their mood. And so they said their increased irritability and frustration when confronted about memory lapses. So when somebody's confronted, when the patient's confronted from their family, what we're seeing is that they are irritable and frustrated. So that right there is how I get at the behavioral change. So I might ask something on the lines of, you know, are there any changes in his behavior? You can ask a very face valid question there, and then they might say this irritability or frustration. So that's one way to get at the behavioral change. The next one is visual spatial difficulties. So, you know, you ask a question related to them being able to drive or to get home or getting lost, and they say they have difficulty following directions in new environments, and one time forgot how to get home from church. They attended that church for 5 years, but it was only one time though. So that's a response we get a lot of, like, well, that's an indication there could be some visual spatial difficulties. The next one is, have they fell for any scams or anything as far as poor judgment? And so they said, yes, a few months ago, there was a scam, and they lost $500. And they've never fell for a scam before. So there we might get at some executive functioning slash poor decision making pieces. The next one would be under memory as well. So they have to, or memory. So maybe they're starting to write themselves a lot of notes about everything, taking their medication, and whatnot. So you might say, so how are they doing as far as remembering to do things that they normally do, such as taking the medication? And she responded, has to write himself notes to take his medication, but is able to manage on his own. So this is really important. Because what we're getting at is there are these compensatory behaviors, and sometimes it's just aging, but now they're using things like post-it notes and other things to remind himself to do these things. Um, and then we're getting at, visual spatial difficulties as well. Any accidents recently, any tickets, we see people that might get tickets. And so wife reported a recent fender bender when trying to park. And a lot of times you'll see patients as well as caregivers minimize and use minimization with their responses. So just be aware of kind of the wording that I'm using. You might get some of these responses, it was only one time, or it was just a fender bender as a little thing. So those are things to think about. And then Mr. Smith specifically, you might ask Mr. Smith, um, tell me, have you ever had times recently where you couldn't think of the right word? And he says, I sometimes cannot figure out the correct word to say. And your follow-up question would be, well, how often is this? Is this daily, or is this monthly? Is this multiple times a day? And so these questions or these answers that we're getting can tell us a lot. So if somebody came to me with this kind of presentation, this would be an obvious one that I would send to a neurologist for further workup, or to a memory care clinic, because this would be kind of clear cut. What you'll see sometimes, though, is you might see Mr. Smith reporting, nope, I always think of the right words. I did get an offender bender, and I did fall for a scam, but my memory feels pretty good, and it feels like those are just fluke things. That's where you have to make more of a more challenging decision if you want to send or not to do that. And that's where I would probably recommend maybe doing a screen or other things that I'm going to talk about in a second, as well, that you can do. To see if it's required for them to get into a neurologist, because it is hard to get into neurology or memory clinics. It can be many months. So something to think about. So let's say that this patient comes to us or comes to your clinic. What would be the next steps? And so one of the things that Dr. Bertelson and I have talked a lot about is how can we, especially because we now have medication to slow the progression of the disease, what are things that primary care physicians or other physicians that are referring providers can do to help speed up the process that we have in our clinics? And so one of the things that we have talked about, if before you send to neurology or a memory clinic, making sure they have full labs. Now, we don't, and Dr. Burson, we don't, there's two biomarkers out there. We don't need you guys necessarily to get those, but full labs are really helpful to see, to rule out if there are other deficits. Um, Also giving screeners if you have time. This is a hard one because I know these screeners can take, 10, 15 minutes, but they can be really helpful to us. And so, MMSE, MOCA, or slums, be careful with the MOCA if you have somebody that has an education under a high school education, because the MOCA isn't as great. I would use the slums or the MMSE. I'm not a huge screener fan, but I think it can be helpful in certain settings. And then if they have a recent MRI, or you can order an MRI, those are all helpful. Now, that being said, if you can't do any of this, that's okay. You can still send it to us in the memory clinic or to neurology, but this is something that you can definitely do to kind of speed up the process a little bit for them, as well as give us a better indication when they come in during that first visit, where we're just seeing kind of their records, the background. We don't have a ton to work with. If we had a little bit more, it can speed it up as far as getting them on medication, where we don't have to wait for them to get MRI or get full neuropsych testing or things like that. So it might just help. It just helps us a little bit in that way. I know next time Dr. Bertelson will be talking about managing the journey, so I'm very excited to hear his talk of kind of, okay, you've sent it now from this talk to a neurologist, you identify the signs, now what do you do? And so this is going to be really important in him talking about, because I think more and more what's going to happen is that primary care physicians, you guys are already managing it, obviously, but you're going to even manage it at a higher rate. So how our clinic's built here and TTUHSC and the Garrison Institute on Aging is we're built where we actually see the patient for a full eval. We do a full eval. We do R bands, clocks, trails. We send off usually for blood and MRI if we don't have it, or for neuropsych testing. And then we do our consensus review, so our whole team meets. We build care plans for the person with dementia and the family as well. And then what we do is we give recommendations back to the primary care physician of what to do next. And so we want them to actually keep caring for that patient rather than us. And this helps us because we're able to then get them on the right track. And all these things can be managed by a PCP. Now, if they're going on Leqembi or donanemab, that obviously would have to be managed by either us or the we send over to other people to do depending on where they live. But as far as like somebody who's not eligible maybe for those infusions, we will send back. And that keeps it so that our wait list is only about 2 months to get in, rather than some clinics all over the country are closer to 2 years, a year and a half to 2 years, which is very problematic. So I'm glad that he'll be talking a little bit more about that. So thank you for your time. And I think I left about 10 minutes or so for questions as well. So thank you. And I think I need to show this slide too, right, Rachel? Good. Okay. I'll leave it on this slide to make sure that you're doing your evaluation, but I'm here to answer questions.
Yes, and please feel free to drop it in the chat as well. Thank you, Dr. Singer. That was a really good presentation. I love how you broke down the case presentation. So that was very interesting. We have a lot of thank yous in the chat.
Oh, you.
And just a reminder, so one of the main like goals of Echo is that it's an all teach, all learn model. And so like Dr. Singer, you shared your memory screening events that you hold. So
Mhm.
if anybody else in the community, like if you have any resources in your area, please feel free to share them in the discussion post, or you can send them to me and I'll share them as well. And likewise, I do have a few resources that I need to share, and I will share those in a discussion post as well. So, all right, I don't think we have any questions.
Awesome. Well, thank you all for coming, and I appreciate it. Happy to Feel free to email or call us with any questions or things that you have in the future. Appreciate, Rachel, the opportunity to speak as well. Thank you.
Yes, thank you so much. And again, everybody, please remember to fill out our post-session echo survey, so that helps us out tremendously with the future of the program. And again, remember to complete all the steps to receive your CMU credit. So, and like Dr. Singer said, March 11th, we will have Dr. Bertelson again. So please join us at that time as well. So if that's it, I will let everybody go. So thank you, everybody, again. Thank you, Dr. Singer.
Thank you.